Hello, everyone, and welcome to Climate Change and Health, a health policy and bioethics consortium. I'm Carmel Shachar, the Petrie-Flom Center for Health Law Policy, Biotechnology, and Bioethics at Harvard Law School's Executive Director. It's my pleasure to welcome you to this conversation, which I think is one of the most pertinent topics that we could tackle today on a global level. It has such an impact on how everybody lives their lives and will be able to live their lives moving forward. Before we dive into the substance of the event, a few housekeeping items. First, the bulk of this event will be geared to a discussion in which we welcome your questions. If you have a question for our speakers, please submit those questions at any time using the Zoom Q&A feature, which is found in the meeting controls at the bottom of your screen. You're also welcome to join the conversation or even submit questions on Twitter. We're at Petrie-Flom. Hope to see you there. We will be sharing the fully captioned event video with everybody who registered. So you guys, as well as people who registered but maybe weren't able to make it, within 1 to 2 weeks, you should receive an email notifying that it's been captioned and posted. Please share the video with friends, family, colleagues who might find this of interest. If you have any technical issues, I hope you won't, but it's always possible. Please email us at petrie-flom@law.harvard.edu, and we'll do our best to help you. If you are interested in this event and you like what you see, I would suggest signing up for our newsletter. It comes out only twice a month, and it's the best way to keep abreast of what events are happening, what digital symposia are happening on our blog, what scholarship is being put out. Speaking of our blog, I hope that you'll check out Bill of Health, which is our platform for really interesting thought leadership on pressing issues, as well as check out some of our other upcoming events. Our annual conference is going to happen at the end of June. That one is Health Law as Private Law, what private actors can do to address health policy reforms and initiatives. But in the meantime, we have a bunch of events, including a series on psychedelics policies around the world, as well as looking at what can be done to facilitate telehealth practices across state lines. Now, this event is not just run by the Petrie-Flom Center, and we do not want to hog the credit. It is in fact part of the Health Policy and Bioethics Consortium, which is a wonderful series that convenes 2 experts from different fields or vantage points to discuss an important aspect of biomedical innovation or healthcare delivery. They're organized by the Harvard Medical School Center for Bioethics and the Program on Regulation, Therapeutics, and Law, or Portal, at Brigham and Women's Hospital. If you like what you see, then I also suggest that you check out the Center for Bioethics, and we've posted their website, as well as they can be found on Twitter at HMS Bioethics. With all of that housekeeping out of the way, I would like to introduce today's moderator, Alicia El-Yamin, who is a lecturer on law, as well as senior fellow in global health and rights here at the Petrie-Flom Center, and adjunct senior lecturer on health policy management at the Harvard T.H. Chan School of Public Health. It's my pleasure to hand over today's event to you.
Thank you so much, Carmel. And I'm really thrilled to be able to moderate this event. This is exactly what I think the Petrie-Flom Center sort of specializes in, which is crossing disciplines and looking at very cutting edge issues from multiple perspectives. And I myself hope to learn a lot during the discussion today. As Carmel said, it's one of the most pressing issues we could possibly talk about. And we're very fortunate today to have sort of 2 sides of this equation, not just to focus on the impacts of climate change on health, but also to talk about how the health sector contributes potentially to climate change. And then we'll have a Q&A and discussion about what are some of the takeaways and policy recommendations at national and global levels that our two speakers might recommend, as well as any of your other questions. Our first speaker is Dr. Aaron Bernstein, who is the interim director of the Center for Climate Health and the Global Environment at the Harvard T.H. Chan School of Public Health, Sea Change. He's also a pediatrician at Boston Children's Hospital. And take it away, Dr. Bernstein. I'll introduce our second speaker when he speaks.
Thank you very much, Alicia. Pleasure to be with you all. I want to thank Aaron Kesselheim and Leo Rand for the opportunity to be with you. I'm going to make my remarks relatively brief and look forward to the Q&A. And my remarks will really be framed around the question of what is healthcare's responsibility to the issue of climate change. Fortunately, we have Anand Bhopal to tackle one half of the equation, which is the emissions and footprint of healthcare that are substantial. But the other side of the equation is what's the responsibility of healthcare in our day jobs, in our care of patients? And I think I would make 2 points around that. The first gets very quickly to the question of what are the responsibilities of healthcare to the health of people in this country and around the world, even beyond the walls of healthcare institutions. And the second is around health equity. To the first point, there is abundant evidence that climate change, because it makes extreme events, heat waves, hurricanes, wildfires, floods, droughts, and the like, much more dangerous, poses a direct risk to the ability of people like me to deliver care to people who need it. You can see that in the wake of any disaster, whether it is Hurricane Katrina and its effects on New Orleans, the Camp Fire in California, the heat dome in the Pacific Northwest a couple summers ago, and those are just domestic examples. So there is a direct risk from these events to the ability of providers to do our jobs. What is the responsibility of healthcare to our patients to prevent harms from these kinds of disasters? I think that question is squarely in focus here, because if you look at where the bulk of healthcare occurs, it occurs after harms happen. With the effects of climate change on disabling the ability to deliver care, and then, of course, the direct harms of climate change on people, regardless of who you are, where you live, but certainly disproportionately to people who come from lower wealth communities, and especially individuals who have chronic medical conditions or disabled. And I'll talk more of that in my second point. There's a huge health burden that's exacted. So if we limit the responsibility of healthcare to dealing with problems after they occur, which is the lion's share of what we do, I think there's a real question about whether we'll be able to do that in a world where we are looking to warm at least 2 degrees Celsius on average, and likely substantially more. I want to underscore that climate change is not creating new disasters. It's not creating new burdens of disease. It's not inventing power outages that make it harder to do our jobs. It is magnifying these things. Climate change has been called a risk amplifier, and I think that's a very good thing to think about when you think about the intersection of climate, health, and ethics. There's no question that all of the challenges that we face, whether it is access to care, whether it's health disparities, and you can pick your favorite, all of these challenges are going to be made harder because of climate change. And in many cases, they already have. So that's point number 1. Point number 2 is around health disparities. So to achieve health equity requires climate action. For a long time, climate change was seen as a problem for polar bears and ice sheets. I've been involved on climate and health since the 90s. That's when health was not really considered a dimension of climate change by most people. more recently, health has become a major part of the conversation around climate change because it's been so obvious. But we haven't quite bridged the connections between these climate shocks, as they like to call them, and health equity. And yet there's so much evidence that shows, unsurprisingly, that when you do have a disaster, the likes of which I mentioned, health disparities not only are created, but they persist. Some of the best data around this comes from the Katrina cohort, followed by Mary Waters and Gene Rhodes and others, that sees outcomes, disparate outcomes, a decade after the storm. And interestingly, one of the most important predictors of those long-term mental health outcomes they studied was access to medical care in the week after the disaster hit. So these 2 points are connected, which is, if we see the responsibility of healthcare simply to waiting until people are sick, which I don't think anyone would fully argue, but it is, in fact, where most of the resources are dedicated, we not only create a situation that may be untenable for delivery of care altogether, but it is particularly inequitable to the populations who already suffer from the lowest health status, the lowest access to resource. And there have been multiple studies documenting that whether it is floods, hurricanes, fires, and even heat, those exposures are happening disproportionately in low wealth communities, and particularly in the United States, communities of color. So if we don't act on climate change, we can pretty much guarantee that we will be making health disparities greater. And what disparities we see in the United States will pale in comparison to what we see in other nations, and particularly low and middle income nations around the world. There's another dimension of health equity that I would say is also critically important and also under considered, and that's the issue of intergenerational equity. The idea that arguably for the first time in human existence, the choices of people in the present have undue influence on future generations. So sure, humans have transformed the earth, through urbanization, through the harnessing of fossil fuels and mining activities, created vast changes to where, how, and when people will live. But there is nothing to the scale of what climate change is doing to those very issues. And so the question becomes, and I wouldn't be surprised if Anand Bhopal speaks to this point, there's a huge intergenerational equity piece here. What is healthcare's responsibility to that? Now, in the context of care provision, I don't think it is as tangible as those other points around what is our responsibility to delivering better access to care, particularly for individuals who lack it right now. But I do think that one of the areas that healthcare has been remarkably timid on up until relatively recently is in voicing these issues, not just on intergenerational equity, but on health equity more broadly, to policymakers, corporations, and other power brokers in society about what's really at stake here. We often see healthcare trying to protect its interests, and those interests are often seen as reimbursements. But in many people's view, I would say unmitigated climate change is an enormously detrimental force upon the ability of healthcare systems to do work productively writ large. And I think the absence of that understanding is perhaps getting in the way of more advocacy from healthcare to address this issue more broadly, because of course the healthcare sector itself could not do it independently. So those are my 2 points, and I'm delighted to take questions later. Thanks.
Thank you so much, Aaron. Our second speaker is Anand Bhopal, who is the Takimi Fellow at Harvard, is a Takimi Fellow at the Harvard T.H. Chan School of Health at the Takimi Program in International Health. He's also a PhD candidate at the University of Bergen. And I've had the privilege of interacting with Anand through the Bergen Center for Ethics and Priority Setting as well in Bergen, Norway. And Anand, there's already a question in the Q&A saying that if healthcare providers and institutions contribute so minimally to climate change, What are the other possible approaches? So I'm sure you'll have some direct responses to that question in the course of your talk. Take it away.
Hey, so thank you so much for the invitation and introduction, Alicia. Just give me one moment. So I'm absolutely delighted to be here with you all. So as you heard from Ari, climate change clearly presents a threat to health. Now I'm going to present the other side of the coin here, which is how healthcare is contributing to making climate change worse. And the key question, I suppose, at hand here is what is the role of the healthcare sector when it comes to climate policies and advocacy? And again, it has both sides of the coin there. So it doesn't need me to tell you that there are major threats posed by climate change, and these are already present today and will get worse in the future. So of course, it's a huge intergenerational equity question. We also have a really pressing policy problem facing us right now. We have a diminishing, in fact, dwindling carbon budget remaining to stay within the Paris Agreement, the internationally agreed Paris Agreement. And this just shows the remaining carbon budget for a 1.5 degrees. So this is very, very small at this point. At current rates, we would use it up within 7 years. So it's really widely understood that every sector, everywhere, has to do its part, including healthcare. Now, research over the last decade or so has tried to get a better grip on the contribution of healthcare to global emissions. Current best estimates at the moment are around 5% of global emissions are attributable to the healthcare sector. Now, as this graph shows, there's quite wide variation between countries, which I'll mention a bit more detail momentarily. And it's also generally increasing. Now, just for context, 5% is more than flying, it's more than shipping, major polluting industries. And by some accounts, both of them put together. So just so you know what I'm referring to when I talk about emissions from healthcare, this is a breakdown of the emissions profile of the NHS, National Health Service in England. And this shows emissions by source. So really the kind of things that contribute to this carbon footprint, things including travel, anesthetics and inhalers, building energy. There's many things to do with the supply chain. We use a lot of equipment that became very obvious during the COVID-19, height of the COVID-19 pandemic. And medicines are a major contributor. So in a sense, it's everything. It's all the constituent parts of the healthcare system. But really, this is the case whenever you look at the carbon footprint of any system. There are many small parts. Now, there's a few kind of general issues I want to sketch out. Hopefully these will frame some of the questions that people have. Perhaps it isn't surprising to know that healthcare carbon emissions are highest in rich countries. So this is broken up down by World Bank income region, and we can see they're highest in high income countries. This is inverse of unmet healthcare needs, which are of course highest in low income countries. It should be fairly intuitive. It's still unfair. Now, a second point, which perhaps gives a bit more nuance, is that emissions are unequally shared within countries. So this distinction between high and low income is not sufficient. This is from England again. This is breaking down the healthcare carbon footprint as a proportion of individuals' total emissions, depending on their income decile. So 10 being the most well-off and 1 being the worst off. And what you can see that is in the worst off, healthcare as a proportion of an individual's carbon footprint represents almost a quarter of their emissions. Whereas in the richest decile, this is closer to 2%. Now, I think, although this is for the NHS, which has a universal health care system, I think this problem would present itself in a similar, somewhat different way in a setting like the US, where there's quite unequal access to healthcare. So I think a similar trend would be observed. I haven't seen data on this so far. So the question, I suppose, is what do we do about this? So hopefully most of what I've said so far is fairly either intuitive or recognizable. And I want to break down what to do about it into 3 levels: global, health system, and individual level. So firstly, on a global level, a huge shift occurred in November 2021 at the COP26 Climate Summit in Glasgow, where the World Health Organization really took a lead in saying we need to develop climate resilient health systems, but they also need to be sustainable and low carbon. It encouraged countries to sign up to this platform called the COP26 Health Programme. And as you can see from the map, signatories really covered all continents, high, middle, low-income countries as well. So there's a widespread sort of sense in which we need to do something. Now, as I'll mention, it's still unsure exactly what we need to do. So on the individual level, and I imagine there's some clinicians in the audience, perhaps students. So I've just highlighted what I see as some of the key constituents here. So this photo is Dr. Tamsin Ellis, a GP in the UK, riding on her bike to see patients. She's part of the greener practice, green GPs in the UK, really trying to tackle climate change through their practice, through their individual practice. I think students have clearly had an important role, saying we want this on our curriculum. So I noticed that at Harvard, there's been a shift to ensure that all medical students do receive education on climate change on their curriculum. This has really been replicated the world over, a sort of demand. But related to that, there's also advocacy. And I think students have been a really, really important voice here in calling for action. Now, final thing I'd just like to highlight is a lot of energy is going across the world, really, is going into estimating and calculating the carbon footprint of different aspects of our healthcare. So the carbon footprint of different interventions, treatment modalities, medicines, the list goes on. And if you're interested in this Healthcare LCA is a new initiative that was just released that tries to collate all of this growing research into one place. The ethical concerns are beginning to get growing amount of attention. This is a paper that was published about 3 or 4 months ago, really looking into the ethical obligations, responsibilities upon prescribers to prescribe the green alternative, the lower carbon alternative. In this case, they examine different types of inhalers, one of which has a much higher carbon footprint than the other. Now, the aspect that I think personally I'm most interested in, and I wonder if the audience will be concerned about, is we at the health system level. So really, this is what do we do? You're a health policymaker, you want to do something. How do we tackle this? And I think it's fairly clear that health systems already have a huge number of competing concerns. I mean, this is worsened by COVID-19, but of course, we need to try and address healthcare needs. We need to do that equitably. We need to address staff burnout. The list goes on. And the question is, where does sustainability and cutting healthcare's carbon footprint fit into this? Now, I'm just going to throw out one approach to this, and I'm sure we can discuss more, and that's about resource allocation. So a few papers recently have looked at how we integrate carbon emissions into existing resource allocation criteria. These are generally widely used to try and allocate scarce resources, which really typifies healthcare. And in a way, this is quite effective. So if you imagine, for example, you had, actually, just to be clear, so normally when we think about resource allocation, we primarily think about financial cost. We may also be interested in equity concerns, reducing out-of-pocket expenditure. It depends on the setting. So if we were concerned about carbon emissions, at times when you have two alternatives and they're essentially the same price, well, it makes sense. Let's choose the lower carbon option. So that's actually been very effective for reducing the carbon footprint of anesthetic agents. Generally, it doesn't cost more to use the low carbon option. So really, let's just shift that out. Now, on a system-wide scale, it's not always quite so straightforward. So the question is, how do we value carbon emission reductions within the resource allocation criteria? Of course, if the value assigned is too low, it might not significantly affect resource allocation. And too high, well, the risk, of course, is that we sacrifice some health gains. Now, of course, there's an alternative ethical approach, which is to treat the goal of decarbonizing healthcare as really a distinct ethical concern. It's saying, look, it's not really a competition between health and the climate. It's that we have a commitment to deliver health in a low carbon, climate protecting way. The English NHS, for example, recommends a 10% minimum net zero weighting into its procurement mechanisms. It's a way of saying, no, this is actually a primary concern. Now, I'm going to leave it there. I'm sure you have lots of questions. Looking forward to hearing them. Thank you so much.
Thank you so much, Anand. We already do have some questions, and I will intersperse those with some questions of my own. One is something that we had spoken about before the public event started. One person wants to ask you both, and I think I'll give you each in turn a chance to address this, talking about climate change and the impacts on reproductive justice. Would you like to go first, Anand?
Yeah, sure. I mean, I think Ari Bernstein really put the nail on the head when he mentioned about climate change being a risk amplifier. This is really, in a way, climate change is often described in terms of inequality, and inequality is such a useful framing to think about this problem, because it really just heightens and makes ever more clear these existing problems that we already have. So I think, although I haven't studied climate change specifically as it relates to reproductive justice, it's very clear that climate change will affect certain groups more than others, in certain places more than others, at certain times more than others. So it seems to me that there's a clear overlap and intersection. As I say, I haven't studied this specifically, but perhaps Ari Bernstein, Ari, do you have anything to add on that?
I would add a couple things on. The first is that there's good evidence that, climate change, primarily through studies of heat and air quality, there is a clear disproportionate effect on outcomes that is categorically different by wealth status and the United States race. The second is another dimension of reproductive justice that may not be as visible to audiences that are not the ones directly a part of this research. But when you ask young people around the world, as Carol Hickman did 2 years ago, a scholar in, I think she's at Australian National University, but I might be misremembering that. She found that globally, there were 10 nations, 1,000 young people in each nation. Something between 30 and 40% said climate change affected their daily functioning. On a day-to-day basis, the climate crisis was affecting how they behaved. And a large proportion of that concern was around reproduction. To folks who may not have as much time to interface with teenagers and 20-somethings, it may be hard to fathom the extent of distress that is in the average 18 to 25-year-old around the world on this issue. But it is quite profound, and a substantial fraction of it does relate to this issue of reproductive justice. Now, I would also put a pragmatic note to this, which is I'm first and foremost concerned with the inequities of climate, as I spoke about. And the question I always ask myself is, what is the best way to get more people to grapple with what we need to do? I think that's very different for different people. And I think for many people, the idea of reproductive justice, although not described as such, is actually quite powerful. There are very few people I have ever met, and I would be curious to know others' thoughts on this, who like the idea that something external to them could affect their reproductive choice. So I think this is a potentially very potent motivator if framed appropriately to the audience.
Great. I'm going to kind of take a few questions and pull them together because I think they're related. Sort of about accountability and the role of the healthcare sector in advocacy. You know, the example one person in the Q&A gives of physicians' role in the prevention of nuclear war and having co-shared the Nobel Prize. Another person asks about holding large industries that are active polluters to account. And I think there's also now a broad discussion about decolonizing global health with the North, and as Anand, your chart showed, the United States far exceeding other countries in terms of healthcare's contribution, but also just generally the contribution to climate change. So is there a role, because the effects on health are so dramatically acute, is there a role for the healthcare sector and healthcare professionals in advocating for some kind of reparations, accountability, much more active advocacy for accountability? And I'll let each of you answer separately.
I can take this one first, Anand, if that's okay.
Go for it.
So all excellent questions. Let me run the list here. So the IPPNW, one of their co-founders is Eric Shivian, who is a dear friend and colleague. IPPNW shared the Nobel Prize, as was described, for their work in preventing nuclear war. It was a group of physicians in the United States and Russia who I think broke expectations by forming a US-Soviet alliance that had high visibility at a time at the peak of the Cold War. The same paradigm has very much been proposed in the climate sphere. And I would argue that the paradigm of the 80s in physician advocacy on that front needs to change. I would argue that the environmental movement has been largely white and male. And the issues that are of foremost concern to people who are not white and not male are profound here. To me, that speaks to the need to have a more inclusive model that actually elevates voices of those who have the most at stake. So as much as I admire that work, and I would certainly not excuse people like me from being advocates, I think it is more my responsibility to work to elevate those voices than those of physicians, which in the United States is still overwhelmingly white, although fortunately less male. The second, industries to be accountable. So what are physicians' roles to hold industry accountable? This is a really, I think, important question. If you look at the carbon footprint of healthcare, as Anand alluded to, it isn't in the buildings, it's not in the electricity, it's in what we use, it's in the supply chain. So about 70 or 80% of the footprint is in all the stuff we're using. That includes the pharmaceuticals. So here's a problem. Pharmaceuticals are made from fossil fuels. How do we make drugs without fossil fuels? No one yet knows. So we have a real challenge here in technology, which I think we need to be mindful of as we advocate for decarbonization. Plastics are made from fossil fuels. Everything in healthcare is plastic. So we can want to decarbonize healthcare. The lion's share of healthcare is in resources for which we right now have very few alternatives. I mean, Anand's examples are superb, but I would argue that there's a whole swath of things that are really foundationally embedded in fossil fuels. Now, in terms of just industry pollution, I mean, there's a huge amount of progress that's been made in the United States at reducing industrial pollution, air pollution, water pollution. But I would argue that's been exported. So this issue of exported exposure. So as the US tightened our environmental rules, where did that pollution go? It went down the economic ladder. So there's a whole conversation to be had about that globally. But needless to say that the more we use healthcare here, we actually create pollution burdens outside of our country. And the ethics there are not pretty. So yes, I think healthcare leaders absolutely need to have a voice there. I think corporations in the healthcare sector are paying more attention to whether it's incineration of medical waste to pharmaceuticals and water supplies. But the reality is we still have an inequitable gradient in disposal in particular. And then this issue of decolonization of global health. Well, in the sphere of climate change, one of the areas this is critical is that we are exporting our model of care to low and middle income countries. And perhaps the tip of the spear is in access to surgical services. So there is a large movement to deliver access to surgery for very basic things, cesarean sections, appendectomies. If we do that in the image of US healthcare, it will be an unmitigated disaster for everyone. Because of the resource intensivity of what we do, its lack of resilience to climate shocks, it will create a huge carbon footprint. It will create a huge waste footprint, and particularly in pollution in local communities. So we absolutely need to be mindful that exporting our models of care is fraught from any number of dimensions, but particularly in this realm of emissions. I should make one more point, which these three areas reminded me of, which is the National Academy of Medicine right now has an initiative, and in full disclosure, I'm on the steering committee for this initiative, to decarbonize the US healthcare sector. And what to me is remarkable about this is the conversation that is happening between providers, industry, and nonprofits. The National Academy, say what you will about it, it does have pretty good convening power. And so one thing I'm very encouraged by here is that the lines of communication, which are rarely that transparent and available between providers and manufacturers and supply chain distributors, are being forged. It has not been without hiccups, but I would argue on balance, it is enormously important to advancing decarbonization.
Yeah, just if I could pick up on a few of those points. I think really interesting set of questions. So on advocacy, I think this is a fascinating area. I mean, on the one hand, there's something quite practical. So we know that the health argument for climate action is quite powerful. It resonates with policymakers. It resonates with people. So it actually can help with depolarization of climate change as a political issue. So that's clearly very good. We also know that climate change is a major threat to health. So this sort of makes sense, but there is a challenge of what we do about that. And I think something I just observe is, I've noticed in the UK and less sure about in the US, is there's a real shift towards direct action. So a big question is whether healthcare professionals should be protesting in the streets, should be gluing themselves to buildings, drawing attention to this issue as a way of protecting patients. And I think one of the challenges is that this often leads to arrest. Now, Ari mentioned something about the dimensions of advocacy. Whose voices do we hear, and the dominance of people who are often more wealthy and often more white. So this is an issue of who can be arrested. Who feels like they can go and trust the police enough to do these things. I think there are major challenges and questions to be asked about direct action. So I think for me, one of the powerful arguments here is that, what we're trying to do is, with decarbonizing healthcare, I believe, is take responsibility for some emissions. Yes, it's a relatively small amount of global emissions, but actually when you break it down, virtually everything is a small amount of global emissions. Electric cars are a small amount of global emissions, and so on and so on. So I don't think just being a relatively small amount means anything. But I think the key here is that actually what we're trying to do, the whole mechanism behind the Paris Agreement and this sort of polycentric approach is that action inspires action. Trust inspires trust. And actually it's trying to look for some transformational changes in society. So the idea behind decarbonizing healthcare is not only to take responsibility for our own carbon footprint, it's also to show it can be done. And most people actually, I think, have a gut feeling that we wouldn't expect healthcare to go first. So actually demonstrating that something can be done is really powerful. Now, just a final mention about fairness on a global level. I think this idea of fair pathways to net zero healthcare is pretty key, because actually there are hugely different challenges in different parts of the world. And as Ari alluded to, there's huge unmet healthcare needs in much of the world. So these have to be simultaneously addressed and improve access and quality, whilst trying to do it in a low carbon sustainable way. So I think this, these are huge challenges. These require new models of care. And I think this idea of exporting our model of care, of course, that's totally unsustainable at a global scale. But we should be aware that that doesn't just happen explicitly. It's not as though there's someone from the US going and saying, we will replicate here in Ethiopia or Malawi exactly what we have back home. It also kind of happens implicitly, an idea of what is good quality. Often people, my colleagues working in lower income countries, they often want tertiary care. I mean, they learned about the same stuff I did when I was in medical school. So I think we just have to be aware that there is really new models. The questions go far, far bigger than merely trying to cut the carbon footprint. It's actually, how do we deliver healthcare in the future? I'll leave it there.
So there are just a huge number of questions in the Q&A, so I'm going to try to group them, and there are a couple around data and measurement. And I think these primarily go to you, Anand. One is, how were the calculations done to say it's 5.2% in general and break it down that way? And then a second follow-on question from the same or another person in the Q&A is, how would we measure changes in healthcare's contribution to climate change? What kind of data are we drawing on?
Yeah, so at a global level, this is done on these macro life cycle analyses type approaches. So we're looking at where do goods go, how do they move from where, and how much energy and carbon emissions are embedded in those goods. Now, I think it's actually although the headline figure of 5.2% is kind of often referred to, I think it makes far more sense to think about this on a national and subnational level, because then it becomes a bit more tangible, practical, and we can think about what to do. So if you just cast your mind back to when I showed the breakdown of the carbon footprint of the UK health system. So in a way, I think that's in a way much more detailed and reliable. So we can then break that down and look at, say, that 20% that is medicines, or that 10% that is building energy. These are kind of calculated from the bottom up. So I think if I could just add a third dimension there, which is, this is often done on a top-down level, but clinicians and healthcare workers are really have been deriving from the grassroots this move to low carbon healthcare. And a lot of that has been this idea of trying to calculate the carbon footprint of the things that they do and trying to figure out how they could do it in a less polluting way. And I suppose there is a question about how that relates to this the national emissions. But I would just say that it does seem to be having some effect so far. So, for example, in the UK, I've just mentioned it because I know it best. We know that emissions have come down by about a quarter since 1990, whilst the volume of healthcare activity has gone up. And we know roughly this is because of decreasing dependence on fossil fuel energy and various other changes. I think this is a very promising direction to take. However, just to be clear, this is very much a work in progress. It is not clear how best to do this and how best to do it at speed and scale. So this is a very active area of research, not just in measurement, what do we measure and how, but how do we measure progress and how fast should we go?
All right, did you want to add or?
Anand's answer was excellent.
Okay, so this is a question that speaks a little bit to something that each of you said. There's a questioner who's saying, well, yes, maybe exporting the US model of healthcare elsewhere would be horrific. And you had some slides on health system changes, Anand. But the questioner's question really goes to, what if we really need to rethink that and move much more toward preventive care, to public health measures, instead of if the environmental damage is coming from the equipment, coming from the medications, coming from all the plastic that is used in curative care, then can we shift health systems to more public health and preventive approaches? And I guess I'd like to hear both of your comments there.
Well, I don't think I would be doing this if I didn't think it were possible. But I think the question speaks to the fact that it's not easy. And in some ways, you can look at, the climate issue in healthcare as a microcosm of the, even if climate change hadn't been happening, I think many people would say that you look at the US healthcare expenditure and as a percentage of GDP and where it's going, we've got, some people estimate a quarter of deaths are fully preventable and half of healthcare utilization is unnecessary. So, meaning it's by modifiable risk factors. I think this question gets into how we deal with the reality that people respond after disasters happen, but much more so than before. And I think there's some really compelling examples that we can learn from about when we were able to actually do that, to actually act before disasters happen. I think it does depend on good science. I think there needs to be much more investments, and I'm delighted that the NIH has now got a NIH-wide initiative to really focus on climate. But there's got to be evidence showing that prevention is really effective and works. The idea that there's power and prestige in healthcare, and particularly in people with medical degrees, and how that could be threatening to that power dynamic is another important consideration. But what I find interesting, having worked with medical students for a long time, is that almost nobody comes to medical school purely in the mindset that they're going to cure disease. Most folks write in their med school applications that they actually want people to be healthy. But it is only through the power of culture, I would say of acculturation in many cases, that we wind up with providers who can only see because they are only incentivized to deal with after the fact problems. I've seen this most acutely in frontline health clinics like FQHCs and FCCs, where people are working on the front lines in communities that are often underserved because they actually have a vested interest in promoting the health of that community. I think this tension is very apparent there. So I think given not necessary cataclysmic shifts in how we incentivize care provision, particularly in how we train folks. And I'm also encouraged that in medical education, I think there's greater emphasis in a more community-based understanding of what healthcare means, and certainly in social determinants of health, that this is possible. But I would underscore, it's not going to be easy. And I think the question is encouraging that the challenges are not, they are readily seen and understood.
Yeah, and to add to that, I think this idea of prevention gets at the heart of the relationship between health and healthcare. And what we're actually interested in is health. but often the two are conflated. I think so certainly by society as a whole, I think often people will think of health as, or healthcare as being what we're only concerned in, and especially amongst politicians, it can end up being quite centered around healthcare. But if you think about it this way, we already know that there are many ways of improving health at low cost, or even virtually no cost. If you think about it, there are regulations and restrictions that we can put in on, say, smoking, that would improve health. So there's absolutely no doubt, and the list could go on. Now, there are reasons which we don't do those things, but similarly, there are ways in which we can improve health at low carbon or no carbon, and that relates to different kinds of prevention. Now, generally, if we think about prevention as occurring at 3 levels, primary, secondary, and tertiary prevention, I think the low, no carbon options are generally in primary prevention, before people get sick. Now, I think this is the challenge that we face when we talk about new models of care. Actually, tucked away in that discussion is something about what is society willing to accept. If you think about things like we live in a society which carries risks, and there are risks everywhere, and there's a sort of tacit agreement that's the price of our liberty. But actually, when we talk about new models of care, it may mean more restrictions. I suspect in a US context, this might be a hard sell. But there are serious discussions to be had about, what are we willing to accept? Because actually continuing as we are is clearly unsustainable, certainly at a global scale.
So one of the questions, Drill, and there are lots, the Q&A is really very vibrant. One of the questions is about some of the things that both of you have mentioned in different ways, which is the idea of combining decarbonization or fewer emissions with balancing that with equity and quality. And especially in the global south where there are limited resources. And they really want to have some more specifics on how that could be done, on what would be a strategy to implement that in whatever area of health.
Perhaps I can just start and just give it a few general thoughts on how you would approach this. Now, in a way, if we think about it this way, we've got two main options. So one is if you come back to what I mentioned about resource allocation processes, these occur to a different degree everywhere. There is a way of deciding how to allocate our resources, scarce resources. They're sometimes done in a very formal way, with set criteria, sometimes less so. So the question is, in a way, can we incorporate those emission reductions into those criteria? And generally, that would require setting a value on emissions reduction, saying this is how much this is how much we want it, and in comparison to these other things. Now, just to be clear, we already do this with often in resource allocation.
Sorry,
Oh, yeah.
just a value in the sense of certain amount of life years saved or quality saved, or
yeah, so let's just make it practical then. So you are thinking about how you would spend $1,000 in healthcare. Let's use Ethiopia as an example. Now, the criteria that are already used, so one would be health benefit, health gain. One would be health equity, so who does it benefit within that society? And so making sure it helps the worst off. And the third is about protecting people from out-of-pocket expenditure and potentially catastrophic expenditures. And already we have sort of systems and ways of thinking about how do you balance those 3 factors. So the question is, could you add in a 4th? Now, of course, that's one option. I just want to be clear that that's one way of doing it. Another is to say, no, actually, we just need to change the way healthcare is. So it's much more of a foundational ethical concern. We need low carbon healthcare, and healthcare inequality. So it's not really a trade-off as such. It's saying, no, we need this. Now, on the one hand, that sounds quite appealing. We just need low carbon healthcare. But there is implicitly, of course, some sort of opportunity cost tucked away in there, whether you realize it straight away or not. And I think this is where the question was really focusing on low and middle income countries. And I think this is where it's quite challenging. I think it's quite unreasonable, actually, to expect low and middle income countries to prioritize decarbonizing their healthcare systems, especially when there's so much unmet need and there's so much need to improve access and quality. So I actually think this calls for kind of much more innovative financial mechanisms to try and make sure that this is financed. It needs more research to try and figure out where the win-wins. So how can we reduce carbon emissions whilst improving health? And I actually think on a global level, we also need to see the health sector as supporting one another. Ari alluded to supply chains. So a lot of healthcare is actually quite globally entwined. So what we have to recognize is, I think there's an onus on the rich countries, which have been historically the highest emitters, to take a lead, to really reduce emissions quickly. This is not purely as just doing a right thing or being good. It's actually the onus of responsibility lies there to give some low and middle income countries some breathing room to do the same.
So I'll add just a couple points to what Anand said.
Please.
The first is that the best way to decarbonize healthcare is to not use healthcare, or at least sick care, as we commonly do. So if someone's healthy and they don't need healthcare, you don't expend a lot of resources. So I think there is this concern that you would compromise access or quality for the sake of sustainability, but I think that doesn't have to be there. The world's, well, it used to be the world's, it's now the Western Hemisphere's largest solar-powered hospital is in Mirebalais, Haiti. That hospital is providing care off the grid, and it's providing access when the power goes out everywhere else. So in that case, sustainability actually is about delivering higher quality care. And we see increasingly in lower income countries, solar power, and there are lots of examples now where solarization has actually been a win-win for sustainability and access. To Anand's point about financing, so the funds that have mostly come through the UN process to support climate resilience have to date largely not included healthcare as a specific focus, but that has changed. I think through advocacy, there has been a recognition that those funds should actually focus on healthcare, because the reality is that what I mentioned in the context of the US with these climate shocks disabling health systems, there's a huge health equity grievance. So if you actually want to advance global health access, you need to have climate resilient health facilities. They're actually one and the same. And climate resilient facilities often have solar. They often, I mean, there's a great example of the Butaro Cancer Center in Rwanda, which is the nation's first cancer center. It uses passive ventilation because to create protections against airborne infections. So it uses almost no energy and uses passive ventilation to provide a healthcare quality attribute, which is infectious disease control, with almost no energy use. So this is my point. If that center, that cancer center, had taken a US health system model, it would have put in an enormously intensive air conditioning unit and ventilation system. But fortunately, I should mention that both of those sites, Butaro and Butaro is a part of the health ministry of Rwanda, but is heavily involved with PIH, and PIH was also part of the founding of the Mirebalais Hospital. I would argue that we absolutely could put these two things in contest with each other. We could pit sustainability against quality of care, but there's so many examples now where the climate responsible action is advancing the healthcare access, the delivery of care, continuity of care, that I think that there's some really good reason to believe that we actually need to put sustainability into our idea about what global health access means.
So first of all, I have to say that I was really delighted to hear you mention those two examples, because I also work at Partners in Health as the senior advisor on health policy and human rights. And I might myself have brought those up. Partners in Health has a particularly good record on this, I think, and we have a dedicated staff person thinking through deliberately our strategies and use of materials, who is focusing on climate change and climate justice. And of course, that is a strategy in and of itself, to get all of these organizations focused with dedicated people working on it, mainstreaming these policies within organizations. So we're really out of time. I have one very specific question, which is about marginalized communities. So we talked about reproductive justice, but we've also done activities at Petrie-Flom on climate justice and climate change and disability. There's also obviously questions about, we've seen what has happened in the cold at the border, the US-Mexico border to people. There's also heat, migrant workers in India, et cetera, who often don't have access to healthcare. So do you have any thoughts there about whether health systems should expand in particular because of this heightened emergency, or any other further brief thoughts you have to offer? And then I think we'll have to close.
I think it's my turn to go first. So I'll say first, on the issue of disabilities, this is a hugely underappreciated dimension of climate change risk. So often when people think about the intersection of at-risk populations and climate shocks, the disabled community is not even at the table. I remember some years ago in the class I teach, I had a student who ambulated in a wheelchair, and we were reviewing one of the major cities in this country's heat resilience plan, and they said, clearly no one who ambulates in a wheelchair was involved in this heat plan. And, we can, if we had more time, we can speak specifically to how people who are have limited mobility are particularly at risk in heat events. But then, there's this broader issue of, I would say, as Jennifer Leaning calls them, distressed migrants, which climate change is contributing to immensely. To me, this is about what Anand was talking about around primary prevention. I honestly do not know how health systems deal with tens of millions of people being displaced internally and externally. I mean, sure, we should be doing more, but to me, it's a bit like rearranging deck chairs in the Titanic. This gets back to one of the first questions we had about what's the role of healthcare advocacy. I think healthcare leaders need to appreciate this reality and call urgently for getting the fossil fuels out of the system, because if people expect us to be able to deliver care in a time reasonable way, or create an even greater humanitarian crisis than we already face, we have no choice. In richer countries, what we tend to see is that, distressed migrants, forced migration are pushed to the margins. They are not given care. In less well countries, this is what causes civil wars. So there's really, obviously we need to do more, but I think the message here to me is quite clear that we have no alternative than to decarbonize rapidly. People get into remarkably paralytic analytic discussions about how fast or how much will it cost to decarbonize. The most expensive thing we can do is wait a second longer than to put full steam on getting us off fossil fuels and decarbonizing everything else we can. And the migration issue is foremost among those incalculable expenses to humanity in that equation.
Anand, do you have any last words to add to that very powerful message?
I am very happy to leave it there. It was an excellent way to end, I think.
Okay, well, thank you very much to Ari Bernstein and to Anand Bhopal for this fascinating discussion. As my colleague Carmel said, we will be captioning it for accessibility and placing it up on the website as soon as possible. Thanks all of you for joining us.